I had to debate if we have to treat aggressively patients with non-atherosclerotic stroke with these lipid-lowering agents. And according to current guidelines, we should treat for sure patients with atherosclerosis and with elevated risk of atherosclerosis and atherosclerotic disease. We have to use these lipid-lowering agents. But there is a question if we have to treat patients with, for example, small vessel disease and patients with cardioembolic stroke. Actually, latest studies show that patients with atrial fibrillation-related stroke patients have some benefit from treatment with statins, especially in the scope of survival and in some cases of better functional outcome if we are using that. Also, that is also shown if, for example, for patients with, for example, dissection, they also could have a better functional outcome if we are treating those patients, and they are not having the stroke related to atherosclerosis. Also, there was a nice debate, and according to the result of the debate, we actually I haven't convinced public that we should aggressively lower the lipid LDL levels in these patients, but we should be aware that those patients could also have subclinical atherosclerosis, and they could also, and that could be related to, for example, peripheral artery disease and asymptomatic coronary artery disease. And there was also a question, how often do we screen our patients with stroke for those conditions, such as asymptomatic coronary disease and, of course, for peripheral artery disease. One important topic in this field is that our patient could have familiar hypercholesterolemia, which patients are very, and they also could have non-atherosclerotic cerebrovascular disease in these cases, but they are at higher risk for stroke by themselves. So we should treat those patients aggressively if we found that the patient has, for example, familiar hypercholesterolemia.